Hello, I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure of moderating today's tumor board. We have a very esteemed panel of individuals today with us, and so I'm going to ask them to each introduce themselves.
Hi, I'm Norman Womark. I've been around for a good many years, as perhaps some of you know. I'm chairman of the NSABP Foundation and one of the chairs for NRG Oncology and the contact PI for that group. And I'm professor of surgery at the University of Pittsburgh.
Hi, I'm Tom Buchholz. I'm a breast cancer radiation oncologist. I'm the medical director of Scripps MD Anderson Cancer Center and professor emeritus at MD Anderson Cancer Center in Houston.
Hi there, I'm Sarah Hurvitz. I'm at the University of California, Los Angeles, Johnson Comprehensive Cancer Center. I'm professor of medicine and director of the breast oncology program there.
Hi, I'm not going to tell anybody how long I've been around, but I am the director of imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am primarily a breast imager, but I also do PET imaging as well. So if I come on a PET scan, it does come with a little bit of experience in the background. I am a member at Memorial, which is the equivalent of a professor, and a professor at Cornell Weill as well.
Thank you so much to all of you for joining us today. I look forward to learning from each of you. The next patient, that is a 66-year-old woman with advanced stage 4 ER/PR positive HER2 negative invasive ductal carcinoma of the left breast with metastasis to the liver and the bones. And she has received multiple lines of therapy. She was originally diagnosed in 2015, at which time she underwent bilateral mastectomy. Shortly thereafter, she was found to have osseous metastatic disease to the spine. She has since then received letrozole, an aromatase inhibitor with progressive disease, after 3 years on treatment. She then was receiving treatment with a CDK4/6 inhibitor, palbociclib, in combination with letrozole, and most recently, Alpelisib and Fulvestrant. And so we're going to talk about a little bit more about what we would recommend for her treatment. Again, her original diagnosis was in 2015, at which time she had a strongly ER positive 100%, PR 80%, and HER2 negative cancer. And shortly thereafter, while in the midst of planning for the adjuvant chemotherapy, was found to have diffuse lytic lesions as well as hepatic metastasis. At that time, she was started on letrozole with effective disease control for 3 years. If I might just pause, Dr. Hurvitz, what would be your thought, now, obviously this was in 2015, which was the beginning of CDK4/6 inhibition. But if you were to have this patient today in now 2021 that had metastatic disease at the onset, what would be your choice of treatment in this strongly ER/PR positive patient?
Yeah, I would have used a CDK4/6 inhibitor in combination with the aromatase inhibitor. Now, all of us in our practice have some patients who have done very, very well with single agent endocrine therapy for frontline metastatic ER positive disease. I have a patient in my practice who's 9 years on single agent AI without progression in disease. The trick is that we don't know how to pick out who those patients will be. This patient was able to enjoy a nice 3-year stabilization of her disease with single agent therapy, avoiding the toxicity that is imparted by adding a doublet, for example, CDK4/6 inhibitor. But perhaps, based on the data, this would have been prolonged had a CDK4/6 inhibitor been available at that time. So for now, unless a patient has comorbidities or factors that would preclude them from safely receiving a CDK4/6 inhibitor, that would be my choice in the frontline setting.
Thank you for that. So she was initiated on palbociclib and letrozole subsequently, and disease progression was noted in the fall of 2019 with a biopsy of a right iliac lymph node, which demonstrated invasive ductal cancer, which was ER/PR positive, HER2 negative, and a PIK3CA mutation was noted. Dr. Hurvitz, I will ask you to comment about PIK3CA mutation, the incidence of that in the ER/PR positive patient population, and what are the treatment implications given that finding?
Yes, so PIK3CA mutations are lead to constitutive activation of PI3 kinase. So it allows that pathway to be hyperactive, and has been associated with poorer prognosis and endocrine resistance in ER-positive disease. It occurs anywhere from 30 to 40% of patients with ER-positive breast cancer. And a few years ago, a study called SOLAR-1 evaluated a drug called Alpelisib, which is an alpha-selective PI3 kinase inhibitor. It's an oral drug that inhibits that pathway. The SOLAR-1 study was designed to look at the addition of Alpelisib to Fulvestrant versus Fulvestrant alone in patients whose tumors had a PIK3CA mutation. Now, they did enroll a cohort of patients whose tumors were PIK3CA negative, and those patients did not benefit from Alpelisib. But the primary endpoint in the population of patients with tumor PIK3CA mutations, the addition of Alpelisib significantly improved the progression-free survival on the order of over 5 months. There is no overall survival benefit to date. It wasn't powered to show overall survival, but this is a drug that we now have available in patients whose tumors have a PIK3CA mutation. The study was done primarily in patients who had not received a prior CDK4/6 inhibitor. Only about 6% of the patients on that trial had a prior CDK4/6 inhibitor. However, all the patients had their tumor progress on endocrine therapy. There is a study that Hope Rugo presented at San Antonio called BYLieve, and looking at the use of this combination strategy in patients who had used a prior CDK4/6 inhibitor. And this non-comparative trial supports the activity of this regimen post CDK4/6 inhibitor. So for this particular patient, Alpelisib would be a reasonable option for her, although the toxicity profile certainly needs to be considered.
Thank you for that.
Sarah, do you make anything out of the ATM and MAP3K1, which accompany PIK3CA mutations frequently? Other than prognosis, I don't know of any significance.
No, I was thinking about ATM. In fact, when we were just hearing about this case, Norma, I was thinking, at the time of her metastatic diagnosis in 2015, she should have had germline mutation testing done to open up the possibility of using a PARP inhibitor. Of course, those weren't available in 2015, but now anybody with metastatic disease should have germline testing done. The fact that she's had next-gen sequencing on her tumor suggests she doesn't carry a germline BRCA1 or 2 mutation. There are some studies looking at PARP inhibitors in patients who have somatic ATM mutations and other mutations. So I agree with you, Norm. I think other than prognosis, it doesn't tell us anything about treatment, but it may make her eligible for a clinical trial.
Thank you for that. Thank you for that point. And just to play devil's advocate, let's say that we have the rare case, not the case with this patient, but let's just say we find ourselves in the situation where we have a ER/PR positive patient that has a germline BRCA mutation as well as a PIK3CA mutation. How do you sort of put in order of priority those as predictive treatment biomarkers? What would be your preferred sequence of therapy, given that that particular patient would open a lot of additional therapeutic options?
So it's a great question, because some patients, especially those with BRCA2 mutations, will have ER-positive metastatic disease. So we have the availability of all our hormonally targeted therapies, CDK4/6 inhibitors, PI3 kinase pathway inhibitors, single agent endocrine therapy, and now more recently, the PARP inhibitors, 2 of them, olaparib and talazoparib. How to sequence them has not been tested in a clinical trial. So we have no evidence that there is proper sequencing. And so the way I approach a situation like that is looking at the patient's comorbidities and clinical features and the side effect profile of the drugs. CDK4/6 inhibitors are generally quite well tolerated with endocrine therapy, so I keep that as my frontline option. In the second line setting, in a patient with a PIK3CA mutation, I find alpelisib to be very challenging in terms of its toxicity profile. Hyperglycemia, which can be severe diabetes, severe rash without the use of an antihistamine, mouth sores sometimes. We're still, I think, on the steep part of the learning curve as clinicians and really tackling how to make this drug tolerable for patients. So I might be tempted in this particular situation to sequence a PARP inhibitor before alpelisib, but I don't have data to tell me I'm helping the patient in terms of survival with that type of sequencing.
Perfect. One follow-up question: if the patient had brain metastasis, would that influence your choice of sequence?
It wouldn't for me. We don't have a whole lot of data about the blood-brain barrier penetration of these agents. We've got some good evidence that everolimus does penetrate the blood-brain barrier, which is an mTOR inhibitor used mainly now for patients without a tumor PIK3CA mutation. All of these drugs we've been discussing are small molecules. So if a patient has received radiation, stereotactic radiosurgery, or brain surgery, the blood-brain barrier is already more open and these agents may enter. At this point, however, we're not making treatment decisions based on that. If we're looking at CDK4/6 inhibitors, however, abemaciclib has good data supporting its CNS penetration. And so that's a situation where I may use that feature of the CDK4/6 inhibitor to select a CDK4/6 inhibitor in a patient with brain mets. Again, this patient has huge risk for VTE, already has a PE, so I would not use abemaciclib for her given the 4% risk of VTE with abema.
Perfect. Thank you so much. So in this patient, she was started on alpelisib with fulvestrant in November of 2019 and achieved sort of stable disease until her scans in December of 2020, which demonstrated worsening liver metastasis, although stability of her lytic bone lesions. This patient, again, has hypertension, no significant gynecologic history, no history of tobacco or drug use, and no significant family history. So I'm going to ask if Dr. Jockelson could kind of walk us through this situation that we often find ourselves in as clinicians, where we see sort of a heterogeneous response to treatment and how we best interpret that.
Right. And so, and we haven't really discussed CT versus PET. I'm like the PET princess. And this is one of the cases I like to show to exemplify why I think PET is better. And if anybody hasn't seen, there's a recent article in JNCCN which demonstrates that the cost of a PET CT is equivalent to that of doing a chest, abdomen, pelvic CT, and bone scan. And the amount of radiation that the patient is exposed to is less because the bone scan adds a lot of radiation, so that the fact that there's so many things about the NCCN approving PET, et cetera, is no longer a good excuse. So this is a patient that I actually read one day, and you can see on the left, she has diffuse diffuse bone metastases, but nothing in her liver. And then she was treated, and while the CT scan of the liver demonstrated no change, the lack of uptake in multiple bone metastases demonstrated that she got a response in the bone. However, there was a small focal hypermetabolic focus in the liver, which is not seen on the CT scan. I can promise you, I have scrolled, I have found. So that here's a case where you get this heterogeneous response. If you had done a CT alone, you would not have picked up the fact that it was heterogeneous. I think everyone in this room, but for teaching purposes, is aware that patients with breast cancer get heterogeneous responses. And just a couple quick articles. this is very frequently seen in people who have predominantly bone metastases. And you can see in the study from Clinical Oncology from 2010, 43% of the treatment phases had heterogeneous responses, which I can tell you, having to read these scans with all these different metastases, you really have to be careful, not just to say worse or better. And this was also an interesting study by Lorenz et al. In 48 patients with breast cancer. Half of the patients had HER2 positive disease that lost the genotype in the bone metastases. And again, I think everybody here knows these things can happen, and I just think that it's worth reiterating for teaching purposes. The other thing that I just wanted to show, and this is finally published, I presented this, this is a publication from Penn, looking at molecular imaging to predict response to endocrine treatment. And in this particular case, it's endocrine treatment with palbo. And it's using FES, which is an estradiol tracer, rather than FDG. And as we know that, especially with lower grade ER positive tumors, PET may not be that hypermetabolic, whereas FES, because it is measuring the estradiol in the tumor, is actually a better agent and has recently been FDA approved. And this was a small study that looked at about, I think they originally had 24 patients, and then they now have 30. And so they looked at the likelihood of response to CDK4/6 inhibition. And so it's really about quantifying the estrogen expression. And so again, 27 patients, 600, these are small numbers, but I think it's very impressive, is that if the patients have very FES positive disease, they are more likely to respond to the CD4K agents. Just to show you an example, so this is a patient who has a baseline FES PET. The problem with FES is that it is taken up by the liver, so you really can't look for liver metastases well. But this patient had both FES. You can see there's less uptake on the PET scan than on the FES scan. And then you can see that the patient gets a better response to the palbo because they do have a lot of uptake on FES. Shows a patient who does not take up the FES at all. And you can see this patient does not respond well to palbo. And these are really early data, but I think these are really nice examples of where we could potentially use the various tracers that we have available to predict response to some of these fairly expensive drugs, or some of which are toxic going forward. So.
Thank you so much for that, Dr. Jockelson. Another thing I might ask you to comment on is the difference in terms of using bone scan versus PET scan and the impact of the bone modifying agents. I know often I'm find myself questioning if a patient has received a recent bone modifying agent, if what we're seeing sometimes on the bone scan might be more representative of the impact of the bone modifying agent rather than more disease activity in the bones. Is that something that happens in PET scanning as well?
No, but so it is my true belief that bone scans in, technetium sulfur colloid bone scans and sodium fluoride bone scans are not that great in assessing response to treatment in patients with breast cancer. So I don't believe in using them that much at all. Where we get into a little bit of a problem in patients where you're using PET is if you're using GCSF, or if you're using that, then you will see diffuse uptake throughout the bone marrow as a response to receiving those agents. And so the measurement of SUV is going to be higher diffusely, but you can usually tell progression. I really have not seen very many patients who are getting bone modifying agents, getting bone scans. I don't read bone scans, so it may be that it's a big issue, but I think for me, PET is a much better way. And we've actually, the first paper I wrote when I got to Memorial with Pat Morris, et cetera, we looked at the ability of patients assess tumor response assessment with PET, and it's really much better with PET than it is with a bone scan, because bone scans get hotter when the disease gets worse, and they get hotter when the disease gets better, whereas PET doesn't do that.
Perfect. Okay, thank you so much for that perspective.